And welcome back to the Advancing Health Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, we are pretty excited to have you here. We're excited because we're bringing some real stories and exciting conversations of innovation to life with leaders that are painstakingly, shaping and reshaping the future of healthcare. We're really passionate about a couple different areas. We're passionate about access to care, leadership, and innovation adoption. And if it's your first time tuning in, let me just kind of take a quick step back to tell you, what we're really trying to do here. So the aim is focused on bringing real stories of innovation to life, not just the hoopla, but the wins, the learnings, and highlighting these folks that are in the trenches getting stuff done and making things better and giving them a platform to be able to share their story with our community and ultimately with the world. And if you haven't had an opportunity to look at any of the historical interviews, wherever you are, or if you're listening to this or watching this video, just hit the subscribe button now so that any new interviews come directly to you right to your inbox. So our field, it's constantly evolving, it's moving fast. So it's crucial to have leaders that can envision a future of healthcare differently, more brightly, ones that embrace innovation and that are addressing pressing challenges. And there's really no shortage of pressing challenges, which means that there's just an incredible opportunity to make things better. So today, we are incredibly privileged to have with us a visionary leader that is really at the forefront of healthcare transformation, Dr. Gurdeep Sareen. Gurdeep has been instrumental force in the evolution of population health across the payer, provider, and the integrated pay-vider systems, really pushing the boundaries to drive clinical excellence, affordability, healthcare quality, and profitability. He's currently a board member at the Healthcare Innovation Board at HitLab, where his insights are contributing to the wider adoption and enhancement of health technologies, focusing on patient outcomes. So prior to this, Gurdeep was at Optum Tri-State as the Regional Director of Pharmacy for Population Health. So Gurdeep's a clinician, but he's cultivated some core competencies that have really reshaped patient care paradigms, and hopefully we'll dig into them today. Through his expertise in government programs like STARS and HEDIS, knows a lot around data analytics and digital health and specialty pharmacy. So his enthusiasm for innovation, it's really endless. And his commitment to teaching, doing advisory roles, as well as sort of continuous professional development around the latest trends in digital health and patient care advancements are constantly ongoing. So today we're going to dive into a little bit of Gurdeep's journey, pull out some of these insights and what he's working on and how we can make things better. So Gurdeep, welcome to the show. It's great to see you, man. How are you?
Great to see you, Michael. Thank you for having me on your show. I've listened to a lot of your interviews and podcasts, and they're always really refreshing. And I've known you from some time now, and you're always a great guy to talk with and learn from and exchange ideas with.
Appreciate that. It's always nice to have live jam sessions. You can only read so many articles. The way that you innovate is through relationships, is through connectivity, and it's a privilege to be able to kind of bring really smart, cool people that are doing interesting things to come onto the show. So initially, just sort of thinking about your background, as I mentioned, you're a pharmacist by training. What initially drew you to the field of pharmacy, and how has sort of your career evolved over the years?
Yeah, it's funny. Nothing really drew me to pharmacy. Um, I come from a background of healthcare professionals. My dad's a physician, primary care. Now he's a senior leader. Um, but I had options of become an accountant, become a physician, become a pharmacist. As a in Indian, and maybe true in your background as well, I was given options. This is what you can do, and that's it.
Yeah.
So I didn't like numbers that much, at least not enough to play around every single day, on an Excel. Um, Funny that I do a lot of that now, but uh, I didn't want to see patients every day. This wasn't my driver. I love patient care, but at that time, it was not something that was on top of my mind. And so
Mhm.
I said, okay, fine, I guess I'll do pharmacy. No real interest in it, just seemed to make it enough and be respectable enough, according to my dad. And I found that through my path at school, that I found a pathway where I really enjoyed, where it's clinical meets business, and now expanding that beyond that to clinical meets business meets innovation. And really, that innovation is focused on not just digital. Digital is a piece of it, but
Right.
I alluded to before, right? Like there's so much more than just a book. That's not innovation. Innovation is conversations with different stakeholders. It's breaking down barriers, thinking about problems differently, and just collaborating together.
Mm, mm. So when did you really start to think about innovation? Has your definition of innovation sort of evolved over time as your careers evolved?
Yeah, absolutely. So, early on, I didn't think much about innovation. I'm just trying to learn the trade. I did my residency in medical, and I try to basically figure out how to take clinical information and take that into, business strategy and action and insights. I went down utilization management and value-based care, and where innovation started to really hit is when I earned my MPH from Columbia. So here's where I'm in a classroom with leaders, physicians,
Right.
nurses, non-healthcare professionals. It was an executive program, so I'm really exposed to people who've been in the field and working for years. So between my class and the teachers, I started to think about, well, in this conversation with this one person was from FDNY, another person was a nurse, another was a physician who was, chair of his department. We had so many different perspectives on a problem. And that really created these interesting solutions that had I thought about my alone, or had I even thought about it
Mm,
just the physician and nurse, I may not have come up to those conclusions. And that was so invaluable. I'm like, wait, there's something so much here. There's so much here. Why isn't there more of this? And maybe there was more and I just wasn't involved with it, but I just
mm.
got really interested in the idea of breaking down those silos, having a casual lunch with my classmate and just talking about problems. That's really what drove it.
Fascinating. You mentioned digital health earlier, and it is a spoke on the wheel, right? It's not the entire wheel. And while it's often highlighted, um, sometimes some of the solutions are non-digital. Some of these innovations are non-digital. Uh, have there been any that you've encountered that have significantly sort of impacted patient care and pharmacy care delivery? Well, to the degree that you can, would you mind maybe sort of sharing?
Yeah, of course. So I agree. Digital is not everything. It can be a catalyst in some situations. But for me, innovation and is really about working smarter to create value. And when we think about value in healthcare, it needs to make sense for patients as well and supporting our clinicians as well. One of my responsibilities when looking at total cost of care in a pay vital world is reducing total cost of care. And that doesn't mean choosing the cheapest drug. It just means
Right.
choosing something, being stewards of our resources and choosing something that's cost effective, equally safe, high quality when it's appropriate. And there was an opportunity to save millions of dollars by basically changing how we procure drugs and bill for drugs. However, one of the critical pieces of this is focused on that North Star, our patients. And it would take a lot of time for us to go through all the patients where the opportunity was. And with limited bandwidth, we had to really think about what we can do. Eventually, we found a subset of patients where we saved a portion, but still a substantial amount of money for the organization. But more importantly, as we r reduced copays for these expensive specialty meds, talking about medications that cost, you know, hundreds of dollars on the co-insurance side.
Hmm.
We reduced them to, single to double digits, so like 90% reduction in their copays. And to me, that's beautiful. Anytime you can help the patient make things more affordable, that's makes me proud. That makes me happy to be doing the work that I'm doing. And just to highlight a little bit more about this,
Well, I mean, well, just to interject for a second, I mean, what's the percentage of and I don't know if you have the stats readily available, but what there's probably a percentage of patients that will never take a medication just solely based upon cost. I mean, that inhibitor in and of itself is a barrier to people actually wanting to get better because they are more concerned about the cost of something than the actual benefit of taking it and getting better. They're like, well, I can't afford it. It's a
yeah.
big issue.
Yeah, that's a great point, Michael. So data shows about 50% of people take the medication as prescribed. So this is a cost thing, this is a fear thing, there's side effects because sometimes these diseases are silent, but the medications, their side effects are not. And this comes with a lot of those chronic disease drugs, like drugs to treat hypertension or high blood pressure or high blood sugar or high cholesterol. So those things prevent patients from even taking the medication. But costs, as you mentioned, are the biggest driver of that non-adherence.
Mm, interesting. So when you think about pharmacy and value-based care and where all those pieces sort of fit together, there's a lot of moving parts.
Yes.
Where do you see sort of this transition, having, how's it been successful? What are some of those parts that you maybe people don't necessarily know about? Because there's a lot of moving parts.
Yeah, that's a good question. Pharmacy is evolving and it's changing, and I think, you know, medications, right? Do you know what percent of, do you know that medications are the biggest driver or the biggest or most common intervention to manage disease? So it's 30 to 60% of every office visit at your doctor's office. Those data statistics may vary a little bit, but they all involve a medication management intervention, 30 to
Yeah.
60%. And, this is starting something new, adjusting a dose, stopping a drug. And, what to talk to your question is, as medications are such a big part of healthcare, and as it become more expensive, as it become there are more of them that exists, and people are on more of them, pharmacists are really starting to transition away from just a dispensing role to a clinical role in front of patients. And
Right.
and then this is really like, going from transactional to relational and being part of care teams. And I think this is really driven by, shortages in healthcare professionals and advances in technology. Some
I mean,
people,
listen, if you go anywhere else in the world outside of
Mhm.
the US and you go to visit a pharmacist, many treat their pharmacist as their primary stop prior to even going to see a physician. You go into Africa and Europe and all these other places, like pharmacists are fundamentally viewed differently. What happened in the US? How come it's gotten to the point where, like you mentioned, it's very transactional? Oh, I'm going to go to a pharmacist. They fill out a script. And yet, from a licensure standpoint, a pharmacist can do immeasurably more than what most know that they can do. What are some of those myths about pharmacists that most don't know that, we need to kind of bust here?
Yeah, great question. So I think the things to highlight about pharmacists that many don't know is we are doctorate level experts on medications. We spent 6 years, sometimes more, understanding medications and the disease states. So this positions us like no one else, no other professional comes out of school knowing this much about medications. And they're complex from the administration types to the dosage forms to the side effects, adverse events, contraindications, names. I mean, the names itself are confusing enough. But all these things are in consideration, and we spend a lot of time understanding them. Then we also understand then the disease. And what's maybe particularly interesting is that we are taught the costs. What clinical specialty learns about costs in their initial schooling? From my conversations with other clinicians, none. I hope that's changing, but at least like around the time I graduated and those are around my age and older, not really. And so
Hmm.
that makes us think about how cost effectiveness just in our backbone, like we is ingrained into us.
Well,
And
cost effective and outcome, right? So it's like you can use the lesser expensive option and still get a great outcome. It doesn't need to be expensive and you get a great, I mean, things can be inexpensive and you can get great outcomes. I think there are inspirations, for example. I mean, you mentioned around, sort of your heritage. I believe there's a hospital in India, Apollo hospitals, that do more heart procedures than like any other hospital in the US, and they do them for way less, and they have way less complication rates. So what can we learn from an innovation standpoint overseas and sort of bringing that into the US versus like, well, everything's got to be, we're in first place. We're in first place in one category, which is cost. We're right as of the time of this conversation, we are in 66th place in quality, down from 42nd place. Now we're in
well,
66th place.
um,
That's not a great trend line.
no, it's not a great trend at all. I will say we're probably good at specialty care, but that drives costs. Primary care, prevention, and the outcomes associated, yeah, we're like one of the worst, especially in developed countries, right? I think it's so important to really start to ensure all clinicians, not just pharmacists, not even, and not just doctor levels or clinical focus, MAs, pharmacists, nurses, respiratory therapists, PTs, PAs, working at the top of their license to do the most they can do. Let's be very honest, there is a shortage of healthcare professionals. There is an access issue. You can't see your doctor for months and months at a time. Most patients see their doctor maybe, I would say, less than 3 times. I would say most even less than that, but let's say 3 times. That is not a lot of times. We use our other healthcare professionals to their absolute most potential and use
Mhm.
technology to support these admin repetitive functions. We can really elevate patient care, healthcare delivery, and outcomes and
Mhm.
the professions too. Like I know from pharmacist standpoint, in some states we can't even refill a prescription for a patient who's been on it for 4 years. If we can't reach their doctor, we can't do it. We're not allowed, which seems a little bit ludicrous to me.
Mhm. I mean, what kind of policies, can or from a must be some form of policies and professional groups that are coming together to sort of share some of those concerns, I would imagine.
Yeah, absolutely. There are definitely organizations that focus on this. There are ones that are, pharmacists in managed care called AMCP, pharmacists in health systems called ASHP, and many others. And I think it's important that we continuously support this message of pharmacists and also other healthcare professionals being at the top of their license, expanded scope, and begin to talk about this in a more unified fashion versus just solid towards your own perspective.
Yeah, yeah. I want to allude back to a conversation you and I had a little while ago. It was actually around site of care optimization. And I think the audience ought to know about this. So could you maybe just elaborate a little bit more on that concept of, site of care optimization and really sort of how it contributes to improving, patient affordability and also sort of organizational efficiency?
Yeah, so when we're talking about side of care, in if I talk to a physician or someone else in population health, we all often think about hospital versus non-hospital care.
Right.
In the outpatient setting, if it's affiliated with a hospital, there's a higher cost than not being affiliated with the hospital. When we think about pharmacy, a drug administered in a hospital is more expensive than a drug administered in an outpatient setting that's not affiliated with a hospital. So that's one piece. Second piece is that if you procure, there are two sides that you can kind of procure medications from. One is at your doctor's office, they have ways to buy it
Hmm.
and administer it, and then they basically get reimbursed. So they make whatever the difference is.
Right.
Um, or two is they work with a specialty pharmacy and the pharmacy deals with the cost and the billing, and they just get delivered to the doctor's office, and the doctor's office administers the drug. It's important here that the pharmacy doesn't give it to the patient for the patient to give it to the doctor because there's a safety concern there. We don't know what
Mm.
the test was like, what the conditions were like. That's called brown bagging. White bagging, which I mentioned, where specialty pharmacies deliver to the doctor's office, controls for that better. So when you change that side of care, it impacts the cost to the patient. Sometimes it's more effective to do the buy and bill side, where we doctor buys it. Sometimes it's more effective for us to go to the pharmacy. And it's a complex system on assessing what that actually looks like.
Yeah, imagine you have to do that for, thousands of patients. Is that a piece of technology? Is that an algorithm? Is that sort of a clinical decision tree that sort of maybe funnels people a specific way based on certain set of scenarios and variables?
Well, I think it could be and should be a technology or algorithm because it could be done. I think an algorithm plus an AI bot that kind of does the benefit check would be great. My experience, it hasn't been. It's been manual, where we have great
Hmm.
teams. I mean, they're excellent teams. They're centralized, focused on these aspects. And that's when you have to be very careful and strategic with who are you focused on to convert from one side of the procurement to another, one side of service to another.
Hmm. I'm just kind of thinking of maybe what are some of the other challenges that you see happening in terms of blockers for innovation? What's gotten in the way?
I think, I would say when you talk about innovation, data sharing is one of the biggest ones. I definitely agree that data should be kept secure. Privacy is a big thing, especially with all the breaches and everything else. And that's very important. But sometimes, even within organizations, there's a limitation on sharing data. And you need to share data to innovate, to find your opportunities, to act on the opportunities. But you have to do it in a responsible way. I also think that some people are very comfortable in how things are. It's easy, it flows. Well, maybe not easy, but it's what they're used to. And people typically resist change. So you really have to be ready to, keep on pushing the envelope with data, keep on engaging your network and finding those people who are ready to push the envelope and push the needle. I really think networking is so critical here because that's how I met people like you and
Yeah, I
others.
mean, even just in so for somebody who's watching this, that's maybe in a big organization where they feel like, all right, I'm an individual contributor. What can you say to them? Because you've been in big organizations before, you've gotten initiatives done. Kind
Yeah.
of take us through some of the mindset, the thinking, and the action that's gotten you to be able to get some of those results. Because at the end of the day, I mean, you are impacting patients. You're looking at a pool and a population of patients. Can you maybe share a little bit of that process?
Yeah, of course. So I think one of the first things is making sure you're solving for a problem they care about. It has to be their top few on their list. Because if it's just something kind of on the sides, innovation is not what they're focused on. It should be big impact things. And that's one. Two is have data. Talk to stakeholders, talk to clinicians, talk to leaders, understand the problem from every perspective. And three, be ready to share your solutions, be ready to be shut down, but also be ready to adapt and be nimble, really taking feedback and understanding the why to maybe the no versus just thinking the no. Um,
Well, give us an example. Give us an example of something that you had done, whether it be at Optum or even prior to that, that anything that comes to mind.
so there was an initiative that I did. One was a site of service one, but I'll give another one. But there's an initiative that I did at New York City Health and Hospitals. Without getting into too much detail, I did have an opportunity for a therapeutic interchange
Hmm.
that some were resistant towards. But after understanding the real drivers to that resistance, I spoke with the specialists, understanding that this made sense in a subset of patients, and I was able to drive that change, which saved probably almost $1 million system wide.
Well,
Um, and simple things sometimes like that, while it doesn't sound necessarily innovative, it's things that no one was willing to do before, and changing how we're thinking about it. I would say one other thing is when we're scaling an RPM program across our region. I started asking the question about the RPM program, how quickly are we responding, or how are we responding to critical alerts? Critical alerts, let's say for a patient with CHF, chronic heart failure, could be weight gain of 8 pounds. So
hmm,
how do you respond to that? How quickly do you respond to that? Because RPM is the value is early detection and treatment.
that's right.
So the answer was kind of it could take a couple of days to a week, which to me didn't make any sense.
Yeah, then it's not so critical.
It's not
Critical
so
is like
like,
now.
yeah,
Critical
and
is like, oh, this, if someone says this is critical, I'm like, okay, I'm dropping what I'm doing and I'm attending to that. That's critical.
exactly. So what the reason was is because there are multiple layers of go to the tech organization, then to the care team, then to the doctor, then back, the doctor has to evaluate it, then there are a lot of different things that can break down. And that's the reason. That's it's a truth. That's what happens. Um, so I asked him, why are we waiting for a doctor to respond? We have a general sense of how to at least quickly manage weight gain, right? Usually,
Yeah,
these patients are on diuretics, and you increase the dose by a certain amount. Obviously, it's a little bit more complicated than that, but
of course.
generally speaking, provided some things are not true and other things are true. And so I worked with our region to align on guidelines to respond to these critical alerts faster. So
Hmm.
why shouldn't the care team be to say, all right, actually just increase your dose of Lasix by 50% because for XYZ reason. And the important thing here is to ensure that the cardiologists were on board. And that's
Hmm.
where we were trying to go. We weren't there fully yet, but that's where we're going. Making sure that they're on board with the guidelines and under what situations what was done. And I think that has the real potential to, increase our ability to impact the patient's outcomes.
Hmm. I'm also just thinking, even just amongst all the things that you've mentioned, medication adherence consistently, it remains a critical issue. Um, what would have been some things that you've been thinking about from an information disruption standpoint, to really improve medication adherence, amongst patients?
Yeah, when I think about medication adherence, I think there's two things that are critical. One is you have to, actually have the medication in your hand. So it has to be affordable. You have to get prioritizations and you have to, get medication refills. AI is supporting the last two pieces, which actually reduces admin times by 85%, which is
Right.
huge. But then, of course, the more clinical part of it is taking the medication. And we talked about it, only 50% of people are taking the medications as
Crazy.
prescribed. Yeah, it's absolutely insane how 50% of people are taking it as prescribed, and that's a mainstay of managing disease. And then you have healthcare professionals, when you go to a doctor's office and let's say I go in and I hypothetically have hypertension, and they see my blood pressure is still high. Oh, well, let's increase your dose. Oh, let's add another drug. But they don't know that I was non-adherent. They may have said, hey, have you been taking your medication? The truth is they have maybe 10 to 20 minutes for the entire visit. So they may spend a few minutes at the very best on the adherence part. So how do we then better equip our doctors, our clinicians, providers with the right data at point of care?
Mm.
Um, so that's actually some of the work that we did at Optum. We had pharmacist-led med management for CHF and COPD. And our pharmacists would look at opportunities to improve guideline-directed therapy, but also um, to identify adherence gaps and then speak to the
Mm.
patient and communicate to the doctor that, hey, doctor, letting you know John Smith wasn't adherent to his drug. I've spoken with them, uh, or I didn't get a chance to speak with them because they haven't picked up, but these are the highlights. You may want to spend a couple minutes on that. So that's really impactful. That gives the data to the doctors right away. And some EMR systems do provide this data.
Hmm.
Um, Increasingly, I'm seeing it, but these are usually the big EMRs from my experience. And what data that they're sharing, it's based on claims data, which is called proportion of days covered, which is like a payer term. Um, it's easy to scale because it's using claims, but it's not always fully accurate. Some
Mm.
people are flagged as adherent, but they're really not. Some are flagged as non-adherent, but they're actually adherent. And that's what kind of opens up technology here, the opportunity for technology. There are, different devices that can actually help track adherence. Everything from like a pill box that, has a sensor on the top, or
Hmm.
dose that has a sensor, to actually devices with sensors embedded in the system.
Yeah.
And
Shout out, by the way, to Dr. Matthew Tabakin from MedSense, who's, they've been tackling that problem. He was a wonderful guest on the show a while back.
oh yeah, and that's such an important thing. Like, how do you know true adherence? And but then you have to step back. I'm going to put my payer hat on for a second and say, well, these it's so important to understand true adherence because adherence means better outcomes. But these are really, really expensive interventions. Are we paying for all
That's
of
right.
them? I would love to pay for everything and it all help the patient. The truth is, when it's expensive, how do we justify the additional cost? Who will benefit the most from that intervention? Likely those who are not adherent or have risks of non-adherence, likely those with complicated medication regimens, ambulatory sensitive conditions, chronic conditions, some Venn diagram of all these things. Um, and then once we understand who benefits the most, are we even able to convert them from non-adherent to adherent?
Mm.
And how will we convert them? Because if we can't convert them, what's the point of knowing they're not adherent? The value of the true adherence screen is to make them adherent.
Mm.
And
That's right.
yeah, so I
So
think it's
yeah, just kind of rounding out, the discussion, just sort of looking ahead,
yeah,
because, you're innovating, you're constantly looking, what can we do to sort of shape the future? When when you're looking at the future of what sort of pharmacy looks like and the way that it really entrenches itself inside of care delivery, how how do you think some of your peers ought to kind of prepare for some of these changes? And what are some of those trends that you're seeing emerge now that you think are going to be sort of mainstay in a few years from now? So pick up your crystal ball and tell us what you think.
Yeah, let me rub it a little bit and see what it's. It's a little cloudy. I understand what pharmacists should do and where pharmacy is going. I think a lot of pharmacists are trying to do it, pushing the envelope. They're often very hungry to show the value they bring. And I think they should continue doing that when they are. I think, you know, every pharmacist should be thinking about the value that they can bring in value-based care. I said value twice, but the opportunity that they have in value-based care, how do they think differently and shift from dispensers to clinicians? And I'm
Mhm.
seeing this actually happening. A friend of mine, he owns several pharmacies in the region. He's not even not
Okay.
a pharmacist, but he owns, I think, like 12, 13 pharmacies. Doing great revenue standpoint, you make good money when you have so many and scale it right. But he's like, that's not enough. Let me do more. There's more here. He started employing clinical pharmacists and central teams to help people stay adherent, to look at total cost of care initiatives and drive value there. So he's trying to, pave the path to what community value-based care pharmacy means.
Mm. Is that a new
And
category?
I
Community
think
value-based
so.
care pharmacy?
We are the most accessible healthcare professional in the nation. There are less pharmacy deserts than there are, you know, hospital deserts.
Mm.
Think about that. You can use this as a hub for providing real clinical outcomes and care. Like we're already doing some screenings, we're doing some vaccinations, we're doing some chronic disease management. But as this expands and technology takes over some of the more mundane, repetitive tasks, which I think that's where technology is best at this point, we can get to the front, change the models of how we provide care, and really show that we're indispensable in value-based care.
Amazing. So let's just sort of sign off. And what's the best way for people to kind of learn more about the work that you're doing, and just sort of keep tabs on what you have planned for the future?
Yeah, please just reach out on LinkedIn. Happy to talk with anyone about pharmacy, value-based care, innovation, partnerships.
Tremendous. All right. So for those who've tuned in, it's been an awesome conversation. Lots of golden nuggets, lots of takeaways. If you've seen it and you've enjoyed it, would you mind sharing it on social media, even just sort of indicating and highlighting what are some of the things that really stood out to you? It's good sort of feedback loop for us to see how we can kind of continue to provide value. So, Gurdeep, it's great to see you. Look forward to seeing the next one.
Take care. Great to be here.